Hello everyone, my name is Kyle Burke, and today I will be discussing the effect of facial effleurage on serum complement C3 during acute rhinosinusitis, which was a randomized controlled study. Acute rhinosinusitis is one of the most common conditions treated in ambulatory care, affecting 1 in 7 adults in the U.S. annually. Inflammation of the sinuses and nasal mucosa define this condition and lead to symptoms such as facial pain, pressure, or fullness, purulent rhinorrhea, and even toothache. There are several etiologies for this condition and include viral, bacterial, allergic, and fungal. Most cases are determined to have a viral etiology, however, many physicians throughout the nation still prescribe antibiotics for this condition. Facial effleurage is an osteopathic manipulative treatment, or OMT, with the overall purpose of mobilizing lymph and increasing circulation within a localized area. Another function is to decrease obstruction and pain, especially in the context of acute rhinosinusitis. The mechanism of action of facial effleurage has yet to be clarified and verified in clinical studies. We set out to study the direct impact of facial effleurage's ability to move lymph in rhinosinusitis patients whose lymph movement is likely impaired by sinus congestion, and the immunological impacts of facial effleurage on the course of disease. We specifically assess changes in serum complement component 3, or C3, an important part of the innate immune system, key to fighting off various pathogens before and after facial effleurage treatment. Complement is comprised of a variety of liver-derived circulating plasma proteins that protect against microbes, including bacteria and viruses, through various mechanisms, such as opsonization, direct lytic action, and activation of the inflammatory response. There are three pathways to complement activation, all culminating in the membrane attack complex, which leads to the elimination of the invader. Figure 1 depicts the three pathways in the order in which each successive step is activated. C3 is the common point for all three pathways and is both an inflammatory biomarker and active immunogenic protein, which spells for a great biomarker to follow for facial effleurage's effects. There is little to no information on complement levels in those suffering from acute rhinosinusitis or on facial effleurage and its effect on serum complement concentrations. Facial effleurage has the potential to contribute to inflammation resolution through the removal of lymphatic obstructions, allowing complement proteins to enter the proper tissues and target infected cells or bacteria in the area. This study aimed to elucidate whether serum complement protein concentrations are significantly changed in acute rhinosinusitis and whether facial effleurage directly affected those levels, contributing to the mechanism of action of this therapy. All participants were recruited from the area surrounding Spartanburg, South Carolina. There are a total of 91 participants in this study. Statistical analysis was performed within Microsoft Excel. Students' t-tests were used to detect significance between each treatment group, and all graphs were created using GraphPad Prism. A p-value less than 0.05 to find significance. Each participant was determined to either have acute rhinosinusitis if they had anterior or posterior mucopurulent drainage and nasal obstruction or facial pressure, or be healthy if they had no acute disease. Participants were assigned a random unique identifier corresponding to one of 8 treatment groups as seen in Figure 2. Participants who received antibiotics were prescribed the appropriate antibiotic as determined by the physician in the clinic, typically amoxicillin plus or minus clavulanate or azithromycin for 5 to 10 days, which was started on day 1 following their initial visit. The study involved 2 clinic visits, an initial visit where either no treatment, sham treatment, or facial effleurage was administered, and a follow-up visit 7 to 10 days later. Serum samples were obtained prior to treatment, 1 hour following treatment, and at a 1 week follow-up visit. ELISA was performed in each sample to obtain serum C3 concentrations. This diagram depicts the techniques included in the facial effleurage protocol. We began with thoracic inlet release to facilitate lymph drainage downstream. Following thoracic inlet release, suboccipital release, gall rest maneuver, and auricular drainage were performed. Lastly, facial effleurage was performed, which included rhythmic pressure over the frontal and maxillary sinuses. The sham treatment was performed by the study coordinator, who performed the same movements and positions as the physician. However, they did not supply any therapeutic pressure. Each of these videos depicts the treatment shown in the figure above. ELISAs were performed on pretreatment serum samples from 36 healthy and 55 rhinosinusitis participants to obtain C3 serum concentrations. There was no significant difference in average baseline C3 serum concentrations between healthy and rhinosinusitis participants as shown in Figure 3. However, rhinosinusitis participants who received antibiotics and facial ephthalmology had significantly lower average serum C3 concentrations 1 hour after facial ephthalmology than rhinosinusitis participants who received the physical touch sham treatment. It is worth noting that at the 1 hour time point, participants had not begun their antibiotics yet. They had effectively only received facial ephthalmology. Unfortunately, there were no other significant differences in average serum C3 concentrations 1 hour post treatment or 7 to 10 days post treatment, as shown in Figure 4. Excitingly, in rhinosinusitis participants, there was a significant decrease in average serum C3 concentration 1 hour after facial ephthalmology compared to the sham treatment. This suggests that OMT is capable of quickly influencing protein levels circulating in the blood. Furthermore, facial ephthalmology expressed superiority to the sham treatment, indicating that this effect is not due to inherent changes in lymph when a patient moves to different positions. Decreased serum C3 concentrations after facial ephthalmology in rhinosinusitis participants could be explained by facial ephthalmology's proposed mechanism of action. Facial ephthalmology mobilizes lymph within the sinuses and allows C3 to enter the decongested interstitial space. This movement from circulation to the interstitial space would lead to a decrease in serum C3 concentration. To the best of our knowledge, this is the first time facial ephthalmology has been studied up to 10 days after treatment. Given that we can detect differences in serum C3 concentrations 1 hour but not 7 to 10 days after treatment, facial ephthalmology's effect on C3 may be short-lived. This is not surprising because complement proteins are considered acute phase proteins and are typically associated with the initial stages of inflammation. Facial ephthalmology's other potential immunological effects, however, may stretch beyond the initial day of treatment. To better clarify how long the immunological impact of facial ephthalmology persists, further studies collecting serum at different time points post-treatment are needed. Our study was limited by small sample sizes in each treatment group. Our data provide the first evidence of a potential mechanism of action for facial ephthalmology and how it can benefit patients suffering from rhinosinusitis. We suggest facial ephthalmology and other forms of OMT should be used as an additional treatment for acute rhinosinusitis. Thank you for your time today.